I was waiting for that. Go ahead.
Yeah?
Okay.
Is it okay if we start right now? Okay.
Okay. Sure.
Yeah. What's up?
Okay. So it's morning that side. It's afternoon here. It's 5 minutes past 5 p.m. So I have a 49-year-old female.
Ooh, Dr. Nalucha, I'm so
1 week history of ability.
I'm sorry, Dr. Nalucha.
Sorry.
I'm sorry, Dr. Nalucha, I'll interrupt you. Just a quick moment so that everybody can introduce each other and we can get get to know you a little bit more before we start with the case. Is that okay?
Oh, okay. No problem. I guess I was too excited.
Yeah, we love the excitement. Thank you so much. So hi, everybody. We're so excited to have another global virtual morning report. We're so thankful for everybody who had to wake up really early, but we have people from all over the world. So good morning, good afternoon, good night, good evening. We are super excited to have Dr. Nalucha here. We'll introduce her in a little bit. And I just wanted to do the intro of what's happening now on Global Virtual Morning Reports. We've invited programs from all over the world so that we can learn more about the cultural aspect and the geographical aspect from that is involved in the clinical reasoning. And we also really love to hear different voices and get to know our colleagues from all over the world. So this is a special global virtual morning report, and it's also like the neuro version. We have Gabby and Vale here who are going to be our scribers and our teaching points, and I think you all know them really well. And we also have Aaron, who's going to be facilitating. Aaron, do you want to say hi?
Yes, hello everyone. I think I know most friendly faces in their Zoom boxes here or names. I'm a neurologist in Los Angeles, part of the CP Solvers team, and really grateful to Maria and friends for arranging these global morning reports and for making a neurology one. And it's, well, it's special because it's neurology, but also special because we get to discuss a case with Dr. Nalucha, who's one of the senior residents at University Teaching Hospital in Zambia, where my colleague, Dr. Diana Saylor from Johns Hopkins lives and works and is involved in this program, and invited me to do a series of lectures at 6 a.m. California time, 5 p.m. Zambia time for the last couple of months. So I got to know Dr. Nalucha and her colleagues virtually in that context, and we're excited to have her present a case in the usual CP Solvers format for maybe the first half or so. Maria is going to keep me on time, and then we'll get to discuss with Dr. Nalucha a little bit about living and working in Zambia and learning medicine in Zambia, which will be a lot of fun. So Dr. Nalucha, do you want to introduce yourself a little bit so people know a little bit where you are in your training and where you work, and if they might not know where Zambia is on the map, and then we'll discuss the case together.
Okay, sure. Hello, everybody. Thank you for having me. So I'm Nalucha. When you look at it, it reads Naluka, but it's pronounced as Nalucha. I'm from Zambia. It's in Southern Africa. Initially, we were in Central Africa. I don't know how we moved to Southern Africa. So I say we're in Central Southern Africa. And in the capital city, Lusaka. So I work from the tertiary hospital I think that's the most tertiary hospital in the country. So I'm an internal medicine specialist, and I'm in my final year of neurology residency program. So Zambia is like low to middle income country. So we're still in the limited resource settings. So even when we look at patients, we have to really think through, when you're looking at investigations, you have to think which is the best investigation I can request for, considering the financial situation. So we don't order a band of tests or a whole range of tests. We have to really look at which one is very critical to our management of the patients.
Great. Actually, let me ask you before we talk about the case. I think you may know, or maybe we haven't talked about this, but when I was a resident, I spent 1 month a year working in your neighbor, Malawi, and worked at the main tertiary hospital in Blantyre. And there was an MRI machine there for research, and the internal medicine service was allowed 10 MRI scans per month only. And the service was about 300 patients generally. So in the US, as you know, we get MRIs. Sometimes patients get multiple MRIs in a week to figure something out. And I remember thinking, what day of the month is it? How many MRIs have we used? Should we get an MRI or not? Do you have, I know there are limits on what tests you have. Are there also limits on the number you can do something like that?
Well, the challenges are similar. We have an MRI at my hospital, but it's been down, I think, since November last year. So, and also, actually, even our CT scan machine has been down for about 3 months or so. So for any neuroimaging, patients have to go to another hospital to have the neuroimaging done. And of course, we have to provide an ambulance for them, and that's also a challenge.
Yeah. And Maria's smiling. She thinks maybe I'm trying to get a clue of whether there was an MRI in this case or not. No, I'm just asking so people can understand a little bit about many, not all, but I won't even say many. A few I see are colleagues from the United States who know we get way too many tests, and it sort of challenges our clinical reasoning because we have too much information and some of it is not actually that useful. But we're talking, as you said, about the other extreme where the bedside exam is in some cases all that we're going to have, or even if the resource is available, it's limited, it's expensive sometimes for the patient, and so we have to make some interesting clinical reasoning decisions with less of the information. Great. So if you don't mind, Dr. Lucha, just give us sort of the problem representation only for this case, and then I'll talk with someone in our audience here a little bit about how they might think about it, and then you and I will go back and forth with a little bit of information at a time.
Okay, sure. Okay, so I have a 49-year-old woman who presents with 1 week history of inability to walk.
49-year-old woman with 1 week history, or 1 year history, sorry, of inability. Week. Okay. I thought you said week and someone typed year and I questioned myself. 1 week history of inability to walk. So does anyone in the audience, and if you joined late, this is not our usual morning report where we'll spend 45 minutes on the problem representation. We'll just spend a few minutes. Does anyone want to give a brief summary of how they would start thinking about this case? And I'll do the same, and then we'll get some more information. Any volunteers?
Yeah, I'd be happy to start.
Oh, great. Hi, Mattia. Do you want to just quickly say, I remember you, and we just put you on the podcast, which was great. Do you want to?
I saw. Thanks so much for that, by the way.
Well, you got the diagnosis beautifully. So do you want to tell us briefly, a few minutes, what's going through your mind? And remind me, I know you're from Italy and in the South. Is that right?
Correct. At MUSC right now, PGY2. And by the way, thanks so much for the opportunity to hear about this global neurology and also this initiative in Zambia. I'll try to be as brief as possible in this case. Let's see how.
Me too, but we're neurologists. It's
always challenging. All right, so 1 week history, inability to walk. That's already a lot of interesting information. So we're talking about a woman, talking about someone who's 50. We're talking about a subacute process, acute to subacute, really. It would be really interesting to see whether within this 1 week there was an ictus, and this was actually hyperacute, and this has been chronic after that. Inability to walk already sends me in 15,000 different directions, but where I'm really interested about is whether this is weakness, this is confusion, or this is some kind of apraxia. And I think the way I would think about it is if it's an apraxia or a confusion, there will be a frontal process. And we may see something toxic metabolic, or we may see a lesion within the frontal lobes. So that would be one way to think about it. If it's inability to walk, though, it could also be that we're in involvement of a corticospinal tract. And the level of the lesion of that corticospinal tract would really help us. So if it's a pre-central gyrus problem, like a stroke, and this has happened 1 week ago and has been constant after that, we probably see some involvement of the whole hemibody, or a leg if it's an ACA stroke. Conversely, we may be talking about something within the spinal cord. And if it's something within the spinal cord, I'd be curious to see whether it's just the leg, it's just the arm, but it could spare the face. And by the same token, if it's in the spinal cord, I'd be interested in seeing if it's something involving the surrounding tracts, so if there's any sensory involvement, and so forth. I think accompanying symptoms would also be really important here. But so that would be where we could localize it. Of course, the brainstem is in the middle of the two. And then our exam is going to be key because I only focus on upper motor neuron thus far. It could be lower motor neuron, of course. And in that case, our exam would be key to really discern whether we're doing with upper motor neuron or lower motor neuron. And for the sake of time, I will not start talking about the lower motor neuron differential here. But if we're talking about subacute and we take subacute at face value, then we're dealing either with a toxic metabolic process, we're dealing with an infectious process, or we're dealing with an inflammatory process, or less likely with a neoplastic process. So that's where I would start. I could go further if we want, but I'll try to be mindful of time.
Excellent. Brilliant, Mattia, as always. So yeah, so I agree with you. As you all here know, and Dr. Nalucha knows, the first slide in every of my 11 or 12 talks in Zambia was differential diagnosis equals localization times time course, right? So the time course here, we have 1 week, and you asked a very important question that I'm sure Dr. Nalucha and her colleagues asked, and we'll learn soon. Did this happen suddenly a week ago, and has it been static, or is this something that has evolved over a week? Because those are two very different types of pathophysiology. If it was truly sudden and then static, was this something vascular or traumatic? In this case, if it's been sort of evolving over a week, I agree, we're sort of at the limit of acute into subacute, probably still pretty acute. So if it's been started a week ago and has progressed, is this something inflammatory? Is this something infectious? Probably too fast, as you said, for neoplastic, and then toxic metabolic always on our list. And then you said with a gait disorder, we could go in 15,000 directions. And I agree with you. The way I think about gait is that it's sort of the symphony of all the other aspects of the neurologic exam. So we talk about the 7 parts of the neurologic exam, right? Mental status, cranial nerves, motor, sensory, reflex, coordination, and then gait is last. Why? Well, because you've seen the patient's gait when they walk into your office, right? And sometimes you see the diagnosis right there. There's a foot drop, there's Parkinsonism, there's a magnetic gait, there's ataxia, right? But if you see there's a gait disorder, but it's not really clear what's causing it, as you started telling us, Mattia, it could be anything, right? From the top down. So could this be a cognitive problem? Like you said, a gait apraxia or some type of frontal lobe process where the networks that begin the commands to pattern gait are not working, or something in the basal ganglia, right, where the gait is disrupted? Could this be something more like weakness? The legs are simply weak and the gait is difficult. Could this be sensory loss, such that there's proprioceptive problems and the gait is impacted for that reason? Is it possible that this is ataxia and the gait is impacted for that reason? So any of the subsystems, motor, sensory, or coordination, could be affected alone or together, or something higher order related to gait in the frontal lobes, or the basal ganglia in the frontal lobes, in the sort of cortical regions, or in the subcortical regions. And so, as you said, once we get into motor or sensory, right, are we central, peripheral? Those are all things we'll table until the exam. But I often find it interesting to think about, why is gait at the end? Well, first, you got a sneak peek of it at the beginning when you first met the patient. But second, because if you go through and say, well, the strength in the legs is normal, the sensation is normal, and the coordination is normal, then I know there's something going on with gait that's not making the symphony come together, right? The conductor is not, the instruments work, the conductor is out to lunch, and that means there's something going on upstairs. And just for fun, for morning report, we have to think about where we are in the world, right? And if someone said, I'm going to tell you about a patient with a relatively, not acute, not totally acute, but relatively rapidly evolving gait disorder in Zambia, and we think about base rate of disease, I might already be thinking about some complication of Pott's disease, right? Just to throw it out there, that if you, as Dr. Nalucha would tell us, and when I spent time nearby in Malawi, there's just so much tuberculosis. And so you see so many complications of tuberculosis. And sometimes the radiologist, any mass in the brain will just read, it's a tuberculoma. I would say, well, couldn't it be a tumor and couldn't it be? And they said, yeah, but here it's probably tuberculosis. So we don't have enough information to say that, but just to put it out there that as soon as I heard 1 week history of inability to walk, I wondered, is this going to be a spinal problem and could it be due to POTS disease? But obviously we'll need to know a lot more. Okay, so so Nalucha, if you want to just give us the history, so we'll get a little more information here and maybe pause after that, and then we'll decide if we want to hear the exam at that stage also or chat a little bit.
Okay, sure. Unfortunately, I can't keep my video on. Each time I switch it on, it tells me my internet is unstable, so I don't want to.
It's okay, no problem.
Okay, so she was in her usual state of health until a week ago, when she attempted to get out of bed to go to the bathroom, and she noticed she couldn't move her right lower limb, and she just felt some numbness, but there were no symptoms in the rest of her limbs. And that went on for the whole day. So she was able to try and carry out as much activities as she could with the limitation of not moving her right lower limb. And then the following day, when she woke up, she noticed she couldn't feel both her lower limbs, so the left lower limb was involved, and then she had wet the bed, so she had urine incontinence. And she said she couldn't feel anything, whether you touch her, something hot or cold, so she had complete loss of sensation, but she would have intermittent pin and needle sensation in the lower limbs. And then a day later, she was also stool incontinent and had no urge to pass stool whatsoever. And a little bit of background is that she says she's been having this stabbing back pain for the past 6 months with no change in intensity and mild relief with some over-the-counter analgesia.
Excellent.
So I don't know. Okay, let me pause there and then we can go through the review of systems and the rest of the history.
Yeah, that's okay. If you want to give us Dr. Nalucha, the past medical or medications review systems, I guess everything up to, but not including the physical exam.
Okay, all right, no problem.
Thank you. Great, thank you.
So in her review of systems, of note is about 2 weeks ago, she had a productive cough with some blood-stained sputum, but she said she only had that for a day, and some mild intermittent shortness of breath and no other respiratory symptoms. And then she had drenching night sweats about a month ago, and she reports that she's lost weight over the last few months. She was weighing 75 kgs. Now she's weighing 53 kilograms, and she's had no fever, and the rest of her symptoms are unremarkable. So her past medical history, she's HIV positive since 2012, and she's been on treatment. Initially, she's been on the Atripla formulation, which is tenofovir, lamivudine, and efavirenz, which was switched to tenofovir, lamivudine, and dolutegravir about a year ago. And her CD4 count is 336, and she has undetectable viral load. She was diagnosed with extrapulmonary TB based on pleural effusion on chest X-ray. And this was discovered incidentally when they were trying to investigate her for the back pain. And so she's currently on anti-TB treatment and vitamin B6 for about 6 months now. And she, at that time, she actually had no constitutional symptoms, so it was just incidental. And also, she's a patient who was being treated for cervical cancer. She's had 6 cycles of chemotherapy in 2017, and she's scheduled for another review at the cancer hospital in the next 2 weeks.
Okay, well, go ahead. I'm sorry. Go ahead.
This is the last part of the history. So our socioeconomic history. So she's a teacher by profession, a single mother of 2. She occasionally takes wine, and she doesn't smoke.
Excellent. So there is a lot of information there. In the interest of time, I'm just going to ask one question of the audience that would be a one-word answer, and then I'll discuss. Where is the lesion? Can someone tell me in one word what they think? It can be a couple of words, but not a a neurological discussion of all the possibilities. Where do you think the problem is?
I would have to go with spinal cord personally.
Yeah, so I'm gonna dial it back to one word and just say spine at this point, and I'll tell you why. Very good. Yeah, so there's lots of intriguing stuff we could discuss here, but in the interest of time and to focus on the neurology, right? When I heard sudden onset leg weakness after getting off the toilet, what happens in the bathroom if there was a Valsalva and the patient had a PFO, could have sent paradoxical embolism up to the ACA territory. One of my mentors used to talk about bathroom neurology, that people Valsalva on the toilet and throw a stroke through their PFO. They close their eyes in the shower and have a Romberg sign and fall down, and all the different problems you can, neurologic problems you can have in the bathroom. However, we then hear that this problem is rapidly evolving from one leg to the next. And so you might have been thinking, could this be Guillain-Barré syndrome? It's short ticking along quickly. It's sensory motor. It's the lower extremities. It's ascending. We don't know if it's going to keep ascending. But then once we hear the bowel and bladder, right, that puts us in the spine. And why do I say spine is because I would usually say spinal cord, and I've learned to remind myself that this could also be a cauda equina process, right? Spinal cord or cauda equina, because both of those would affect the lower limbs, both of those would affect bowel or bladder. And I can't say with precision really which one until we hear a little bit more of the exam, although one would suggest that the cauda equina might have some more radiating pain associated with it, since those are nerve roots. So, so Mattia might indeed be correct, but I think first pass we're in the thoracic cord or below, and to have bowel and bladder for me takes the sort of nerves, neuromuscular junction muscles out of it. So we're spinal cord or cauda equina. And so until we heard, even before we heard the cough, I kept thinking, oh, my TB hypothesis is getting stronger, but I also have to be acknowledged of my framing, of my anchoring bias there, because this patient has what sounds like pulmonary tuberculosis, and then we heard they do have pulmonary tuberculosis, but that's not the only thing that could cause trouble back there. And so the only other thing I wanted to comment on here, well, first I'll just say we haven't heard about any trauma, and this is so non-traumatic paraplegia. And there are studies, I believe, actually one in Malawi, which is right next door to Zambia, looking at patients in lower income regions and with non-traumatic paraplegia, non-traumatic spinal problems. And under 50, the most common is TB, and over 50, the most common is metastases. So this patient is right on the cusp of 50, but those would sort of be two predominant hypotheses. And you might say, well, my metastases, would they tick along this fast? Not necessarily if it was a metastasis sort of growing and pressing on something, but if it was a metastasis to the bone and the bone is becoming destroyed and then finally more acutely collapses, that could give a presentation like this. And the other little thing I'll comment here before we hear the exam is patient is HIV positive. And so we have to think about the relationship between HIV and neurology. And the way I frame that, though Dr. Nalucha has a lot more experience and she can tell us as well, given the rates of HIV in Southern Central Africa. So I think of whether this is a direct complication of the HIV virus itself, whether this is an opportunistic infection, or whether this is a complication of the HIV medications. And most of the, so some of the older medications, which are still in use in many parts of the world, can cause a neuropathy, didanosine, stavudine, and zalcitabine. Stavudine can cause all sorts of neuromuscular things as well. Efavirenz can cause psychosis and other altered mental states, but probably these medications that the patient's on we can take off the list. HIV, so we're in the spine, so we'll keep it limited. HIV itself can cause a myelopathy called a vacuolar myelopathy, which affects corticospinal tracts and dorsal columns, just like B12 deficiency. But that is usually a very chronic, indolent, progressive condition, which this patient does not have, and is usually there really at the end stage of the illness. The patient at that time generally has very advanced HIV, AIDS, dementia, et cetera. So the time course wouldn't fit, and the place in the patient's illness wouldn't fit as well. And so what else could be going on here? What other opportunistic infections could we have in the spinal cord or cauda equina? This patient's CD4 count is 326 now, so it's not sort of down in the the lowest ranges where you could see things like CMV radiculitis, which is usually very painful, but could affect the cauda equina. Again, usually those patients are very late stage A's, often also have retinitis, colitis, other complications of CMV, and their CD4 counts less than 50. But anything with a V in it, any virus can cause myelitis, and this is moving along quickly. Could this be a transverse myelitis, a viral cauda equina syndrome like the Ellsberg syndrome caused by HSV-2, or TB, which is itself can affect immunocompetent individuals, but is an opportunistic infection as well. So I think the time course here, the context, and the patient's past medical history are pushing me more towards infection of the cord or cauda equina. And we have to remember, we start thinking about more rare infections or opportunistic infections, but this patient could also simply have an epidural abscess, a bacterial epidural abscess as well, right? That could behave just like this. And sometimes because the patient is immunocompromised or because they're in a TB setting, we start thinking about everything else. And in fact, this could just be a bacterial abscess. So those are some thoughts. Actually, before you tell us the exam, Nalucha, what were you and your team thinking at this point when you heard this history and knew this background and were going to start examining this patient? What was on your differential given the context there in Zambia?
Okay, so as usual, we went through the process. So when she complained of the paraplegia, we thought, is this a CNS problem or it's a peripheral nerve system problem? And then also looking at the time course, the onset is pretty much acute to maybe subacute. And then trying to think, there's bowel, bladder involvement. So we're thinking, okay, this is something that seems to be localizing to the spine. And looking at the onset, we started thinking of what differentials we can have for somebody with an acute problem. And so with her history of the back pain for 6 months, we thought, could it be related to that as well? So we started thinking, is it a myelopathy? Is it something vascular, like maybe an epidural hemorrhage or hematoma? Because sometimes they tend to occur spontaneously, especially for those on anticoagulation. And so even in our drug history, we had to look out for that. She's somebody who was treated for cervical cancer. So we were wondering, did it completely go away? Was it inadequately treated? And now she's got some metastasis that has caused maybe some bone destruction. She's somebody who's being treated for TB already. She's been on treatment for 6 months. And then 2 weeks ago, she's still having some blood-stained sputum. Is she having a drug resistance TB? And then now she's got it affecting the bone, causing some destruction or just causing a transverse myelitis, and maybe a tuberculoma. We thought about something nutritional, like maybe a B12 deficiency, and maybe at the bottom putting some copper deficiency because it can also affect the corticospinal tracts as well. So we were really trying to tease out all that information from her history.
Excellent. Yeah, it's great to hear how you and your team were thinking of this. And you also mentioned the important aspect that probably folks who don't see too much tuberculosis and have just memorized some things for the exams think about TB in the spine as causing Pott's disease, which is spondylodiscitis causing vertebral body destruction or collapse often. But TB can cause a tuberculoma, which are more common in the brain, but can occur in the spinal cord, and can cause an adhesive arachnoiditis, which is sort of, I think of it like a cauda equinitis. That's my term for it. And if this does sort of turn out to be more cauda equina-like on exam, no upper motor neuron signs, et cetera, TB, also lymphoma and sarcoid, just like the cauda equina for some reason. But those are other ways. I know I'm stuck on TB, but that TB can cause problems within the spine. And then cervical cancer, it's interesting to hear you talking about it. Internists and others can tell me in the US, we just don't see too much very advanced cervical cancer because screening is so aggressive. So I thought cervical cancer metastases, I've never seen that, but I remembered being in Malawi and someone mentioned the possibility of testicular cancer metastases to the brain. And I said, does that happen? And they looked at me and said, yeah, of course. Yeah, we see that a lot, whereas we really never see that where it is caught early. So yeah, could this be a cervical cancer that is migrating up the lumbosacral plexus or even metastasizing through the bloodstream? Not something I've seen, but certainly possible also here. Great. So Lucia, why don't you tell us the physical exam and then what you and your team thought the localization was after that, and what you decided to do there in terms of ordering tests and treating things empirically, et cetera.
Okay. So her general exam was actually normal, apart from when we're trying to examine her chest, we found a firm mass underneath her right breast. It was not mobile, it was non-tender on palpation. So we're wondering what that was. And she had, on her examination of the back, she had no gibbous, and she had some tenderness in the thoracic region. So she says that's the back pain she's had for close to 6 months. So she had some tenderness on palpation somewhere around T4. Then for her neurology exam, her higher function and cranial nerves were normal. She had full power neck flexion and extension. And for her motor exam, she had symmetric normal muscle bulk. And in the upper extremities, she had a normal tone with full power in all the muscle groups, and her deep tendon reflexes were generally 2+. And then when we examined her lower limbs, they were flaccid, and she had no spontaneous movement at all, or any movement to pain bilaterally, and her reflexes were all absent. She had a positive Hoffman in the upper limbs and a positive Babinski on the left side, and her right toe was mute, and she had no clonus. And then when we checked for sensation, she had a sensory level to touch, pain, and temperature up to T4, and she also had absent proprioception up to the hip joint. Her coordination in the upper limbs was normal, and of course we couldn't assess for gait because she couldn't move at all. So I don't know what people think from there, or any questions.
Yeah, actually, Dr. Nalucci, you mentioned the patient had no gibbous deformity. Some people in our discussion here might not know what a gibbous deformity is. Can you tell people what that is and why you were looking for it?
Oh, okay. So a gibbous deformity is mostly associated with TB, but it's just when you're palpating the back, it's like it's associated with the collapse of the vertebral body. So it gives a kind of kyphosis. Excellent. Yeah. So this is something you can see and feel on the physical exam when there's bony destruction with TB. And sometimes this is a very subacute and chronic process, and there's bone remodeling, and you can sort of feel what you would see on an X-ray in terms of a deformity. And you also mentioned that there was a Hoffman sign. You and I know very well what the Hoffman sign is, but some folks here might not know what the Hoffman sign is. Can you teach folks a little bit about what that is? Okay, so I just like to shorten it up and say it's like a Babinski in the upper limb. So it may give some, maybe if there's a problem with the corticospinal tract, it may give you a positive Hoffman. Sometimes it's said to also be part of the, when you're looking for frontal release sign, you can have that. And there's still a small percentage that would still give you a positive Hoffman even without any prior problem. Yeah, excellent. I say the same thing. It's a Babinski of the upper extremity. Sort of hold the patient's hand with their hand relaxed and flick the middle finger. And if the fingers and thumb curl, that's a sign of, it's an upper motor neuron sign. Could be brain or spinal cord in that case. Okay, so not too mysterious here, right? There's a Babinski sign, so we know we're upper motor neuron. There's a spinal level. We know we're in the cord. So I think it'll be
rather than me talking, I think it'll be very educational for folks here to hear from you, Dr. Nalucha, what you and your team thought at this stage. And given the constraints you told us before about which tests are available and how easily accessible they are, what did you think of doing next diagnostically? And did you start treating for anything empirically while waiting for those tests?
Okay, so by the time we were consulting neurology service, I think somebody had ordered B12, serum B12 levels already, serum B12 and folate. So those were normal. And I think before the results were out, somebody empirically started on B12, but I don't know why. I just found her on B12 and with her B12 results. And the first thing we thought about was it would be good to get to image her. And we thought we could get an MRI spine quickly so that we could know how to proceed from there. So we ordered an MRI spine, an urgent one, which we managed to get the same day. And I don't know if briefly you can allow me to share my screen so that I just show you the image.
Yeah, let me ask you one question before that. You probably see a lot of B12 deficiency there. I saw a lot when I was working in Haiti. My experience,
Yes, we had a lot of B12 deficiency.
Yeah, my experience, and I was wondering what you thought. The patients say they can't walk, but their strength is, in my experience, very well preserved, and the gait disorder is almost entirely proprioceptive sensory ataxia. They have upper, they have lower motor neuron signs, they have a mix, but they're strong. Have you seen cases, Dr. Nalucha, that are so advanced where the patient is weak or has flaccid paralysis like this, or have you also seen that the gait disorder is usually sensory ataxia?
Yeah, we've seen when they come and then you find it's a proprioception thing, not really a motor.
Not really motor.
Yeah.
Yeah. Okay. I was wondering if that was consistent with your experience. Great. Yeah, we'd love to see the image. I was thinking first, probably if you didn't have MRI there, just even getting a spine film could be very informative here, right? Might not give the answer, but could in this context if we're still thinking about POTS disease. Okay, yeah, we'd love to see.
She had her X-ray, so I managed to look at her X-ray that she took 6 months ago, but I couldn't really, because sometimes you can try and tease out her thoracic vertebrae through the chest X-ray, but then because that's the time she had pleural effusion, and we couldn't really see anything.
I see.
So,
okay.
Yes. So we just thought, looking at what would be the best modality at the moment, we thought let her get an urgent MRI.
Yes. And so, yeah, we'd love to see it.
Let me, so I just got like a picture, put a picture. I was going to show you the whole video, but then it was going to, I didn't get permission to share her identity.
No problem.
So I can do that. Are you able to see my screen?
It's coming.
Okay.
It says you're screen sharing, but it doesn't show us the picture yet.
I move this. Still nothing?
It just says that you've started screen sharing, but we don't see the image.
Okay. Okay, let me stop and try again.
No problem. Or you can describe it also if that's easier.
Just a minute. Okay, so while it's, I don't know why it's so slow.
No problem.
But it's telling me you're screen sharing. So we noticed she had actually, before I mentioned that, from the examination, and we had the sensory level at T4. So we're thinking the pathology is at T4 or anything above T4.
Mm-hmm.
And so we're really interested in looking at her thoracic spine.
Yeah.
Yes, and so, our suspicion was right. She had a compression at, I think this was T2, T3. She had a compression. There's a bit of some hyperintensity in the bone, but the compression was cutting right through the spinal cord. You can't even really see the spinal cord at that level. You can see that it's compressed anteriorly and posteriorly.
So you saw bony destruction with spinal cord compression.
Yes, and I wish it could start showing. I don't know why. And you could tell from the alignment of the vertebra, it looked like she had a fracture because it was really displaced.
I have a diagnosis in mind, I think, but there's probably a few possibilities. So what were you and your team thinking when you saw that image? Okay,
so we're thinking, did she have a Pott's disease that caused the bone destruction? And then now she had this fracture, the disc also herniating right into the spinal cord. So that's what we were thinking about. And also somebody thought, okay, does she have some metastasis? Of course, cervical cancer does have metastasis to the bone, but it's a rare occurrence. So we were thinking more of the TB that was the cause.
Yeah. So how did you decide to treat the patient? It can be very hard without getting tissue then to actually prove if this is TB or not. And the patient we already know TB, though many patients, as you know, and many have extrapulmonary TB without pulmonary TB, but very hard to get someone to operate on such an unstable spine, especially someone able to do so in a resource limited setting. So how did you decide to treat the patient? And then we'll wrap up and with the case and have time to talk more about other aspects.
Okay, so we decided to
Oops, we lost your voice there, Nalucha. Are you still there?
I think we might have lost Dr. Nolicha. And so maybe Gabby and Deborah prepared problem representations in different languages. Maybe they can share them as we wait for Dr. Nolicha to come back. Gabby, if you want to go ahead and speak Portuguese to us.
Yeah, of course. I'm going to show you my second personality in Portuguese. É uma mulher de 49 anos com antecedente pessoal de HIV, com carga viral indetectável e câncer cervical tratado. Se apresenta com uma história de dificuldade para andar por uma semana, disfunção esfincteriana e perda de sensibilidade nos membros inferiores. Ela também teve um antecedente de uma possível infecção por TB, com um quadro de perda de peso, tosse e sudorese há cerca de um mês. E o exame neurológico mostrou nível sensitivo em T4, ausência de reflexos em membros inferiores e um Hoffman e Babinski à direita. That's it.
I won't even pretend that I understood that. But that sounded awesome. I understood Babinski. And now Deborah also had one in Spanish. That's a language that I can understand a little bit more. Deborah, are you there? She doesn't have her video on, so she might not be there. But if anybody else has another problem representation in a different language, maybe Mattia, you can try to do an Italian one, and we'll hear it if anybody's up for it. Drew, if you shared one in English, do you want to go ahead?
Sure, I got one. So 49-year-old woman, HIV positive with cervical cancer and a history of TB, who presents with chronic back pain and subsequent subacute progressive asymmetric weakness with a T4 sensory level. I think that's pretty much all I have on here. At least up to the data that we got, like labs.
I can go with Italian. Una donna 49enne con una storia di una settimana con incapacità, con difficoltà del cammino. Precedentemente aveva un dolore, lamentava un dolore della schiena, ma dopo una settimana non era più capace di alzarsi dal letto e in questa maniera si poi lamentava di un'incapacità dell'urinazione e della defecazione e questo l'ha poi portata a presentarsi all'ospedale con l'incapacità del movimento, completa incapacità del movimento. And that's where we're at.
Thank you so much, Dhruv and Mattia. Deborah is back, so she'll do Spanish, and hopefully Dr. Naluka will be back because this case was so interesting. I have to hear the final diagnosis. Deborah, you're up.
Hello, everyone. Let me do it in Spanish. Mujer, 49 años, HIV positiva con un histórico de TBC, presente dificultad de caminar hace una semana, con una disfunción de los esfínteres y pérdida de la sensibilidad de los miembros inferiores. En el examen neurológico presenta un desnivel sensitivo a nivel de T4 y ausencia de reflejos en los miembros inferiores. Hoffman y Babinski a la derecha.
So I'm sorry we lost Dr. Nalucha to hear the problem representation in the local language in Zambia. I think we were hearing that the conclusion was they were pretty sure this was TB. We just didn't get to hear if they, my guess, that I'm gonna have to wait and see, was that they would probably treat empirically for presumed tuberculosis and follow the course. But we lost the internet, and that is life in the age of transnational Zoom calls in areas of variable bandwidth. Let's see if she came back. But, all right, well,
yeah.
Any questions, or else I'll turn it back to you, Maria, to continue soliciting more languages of problem representation.
I actually have a question. I'm not sure if I was the only one who didn't get this information. Was she being treated for TB for these previous symptoms or not? Did anyone get that?
Yeah, I thought she was treated because I remember hearing B6. Okay, so I think she got isoniazid and B6, but I don't remember if she got the whole thing. Yeah, so you're wondering, would she still get TB? And I think, or could this still be TB, or wouldn't it have been treated? And I think Dr. Nalucha mentioned they wondered if this was going to be MD, drug-resistant TB that might have escaped treatment. I actually don't know if anyone else has more experience with, or many people here may have a lot more experience with TB than I do, that we'd ideally like to ask Nalucha. Do you, how often appropriately treated pulmonary TB? Or are you back? No, Dr. Nalucha?
Oh, yes. Sorry about that. I don't know what happened. I
No
just
problem.
noticed I'm talking to myself, and then suddenly the internet just went off.
No problem. Well, we missed hearing what you were saying to yourself. We were just wondering for you. So how did you go ahead and treat this patient, thinking it was TB is what the last thing we heard? And then a question that had come up that I was curious your answer to, if this is TB and she was treated for that pulmonary TB, does that make you think this could be drug resistant, or is it not uncommon to see patients get treated for pulmonary TB and still then later have extra pulmonary?
So yes, we thought it was TB. We have cases of drug resistance TB, so we were thinking, is it that situation? And considering she was on the treatment for 6 months, and she still she had a history of 2 weeks of productive cough and night sweats, so we were wondering, this is drug resistance TB, and maybe she has some spread to the bone. She now has a Pott's disease that has caused the compression. And then we're still thinking, so I had mentioned like, it's rare that cervical cancer would go to the bone, but we still try to entertain it because we were wondering what that mass was underneath her right breast. And yes, and we didn't have much information about her cancer treatment, so we're wondering, was she fully treated? So we did consult orthospine, who agreed to actually do decompression and also if they could try and relieve whatever was stressing the spinal cord, and also to do a biopsy. So that was the plan. So I was mentioning that she got transferred to the military hospital for the surgery to be done. I'm not sure what the details were. I think maybe the orthospine were comfortable operating from a different facility. I don't know how she got to be transferred. We didn't have that information. And so we were trying to keep tabs on her, see how she would do, or what the orthospine would find, what the biopsy would say. Unfortunately, we only managed to have some information the 2 days before surgery while she was at the military hospital. And of course, the morning she was going into surgery, we were informed. But after that, we did not get any information until a day later when we were told that she had actually died. And we didn't even have much information. So we're still wondering, was it some complication in surgery? Was it during recovery? We don't know what happened. We still don't have that information, unfortunately.
Oh, I'm sorry to hear that. Yeah, so this is probably a very complicated surgery if the spine has already collapsed. So maybe she has this underlying pulmonary disease. But that's very sad for the patient, and also challenging all the time and effort you and your team put in thinking about this case to not know the final diagnosis, though Bayesian reasoning would tell us, right, probably that where there is TB, TB is a major concern. Well, I know we took a lot of time talking about the case, but I'm not sure if Maria is still here, or Gabby or Valeria. I think people, if you have a couple more minutes, Nalucha, I'm sure people would love to hear a little bit more about training in medicine in Zambia. And Maria, did you want to take it from here?
Yeah, Dr. Nalucha, I can't thank you enough. I'm so sorry for the loud music and all of the noise. I'm really, really sorry, but I'm really thankful that you were here.
I actually can't get it.
You can't hear me? Can anybody hear me?
Oh no, I'm saying I can't hear the loud music.
Oh, okay. Thank God. But this was really great. And Aaron, thank you so much for being here. I know it was a busy day for you too. We have to go with like the first mandatory question we ask anybody is, if we ever go to Lusaka to visit you, what food would we have to eat first?
Okay, so our staple food is nshima. It's made from cornmeal. So you have nshima and you eat it with any relish and vegetables. So that's what you would try out. You'd find it everywhere. And then of course we have things like sweet potatoes, pumpkins, cassava. And then the people who eat, I tell them I don't eat insects, but they're these kind of edible caterpillars that people eat. Maybe you may want to try that. I've never tried them. We have the eastern part of Zambia where they actually eat mice. Maybe you'd want to try sample a mouse, I don't know. And then the western half of the country, they eat monitor lizards. It's a delicacy for them too.
Thank you so much for sharing that. I would try anything and everything in this world. So very excited to try mice and caterpillars eventually. And I wanted to ask you, I know that you are very passionate about epilepsy. Can you tell us a little bit more about what epilepsy care looks like in Zambia? We would love to hear that.
Okay, so I had mentioned that we're like a low to middle income country. So we're still having challenges with just diagnostics and drug supply. And then the other thing is, for some time now, we haven't had any neurologists in Zambia until recently when we started the neurology program. So most of our patients were being followed up by psychiatrists. So already trying to deal with that stigma of associating epilepsy with mental health and not a neurological disease is what we're dealing with. And also diagnostic, of course, at the hospital I'm at, that's the only hospital with neurologists in the country. And so we've tried to get all the patients with epilepsy from the psychiatrist. So now they send them over to our neurology clinic. But out there, they're still being seen by psychiatrists, and these are clinical officers. So they're not medical doctors. So they just do a Bachelor of Science in Clinical Medicine for 4 years. And so we call them clinical officers, but they're very handy. There are a lot of them, and they really help us in our health system. So we still have a lot of patients with epilepsy who don't get to see a neurologist. And then also, so diagnostics are very limited because imaging and EEG is only found at the major hospitals. So way down in the grassroots in the community, the hospitals are not able to diagnose it. And sometimes it's just, we depend on clinical diagnosis, of which, of course, epilepsy is a clinical diagnosis. The other challenge is drug supply, and also maybe people need more training on how to choose an AED by the seizure type. But most of the time, people just give what's available. And so sometimes we have an adherence problem, which cannot be patient related or health system related because we have challenge with drugs. So we're still trying to improve epilepsy care with the neurology program. We're sensitizing, lobbying for the Ministry of Health to actually get newer drugs, and of course, see how we can still use the older drugs that we have. So we use a lot of carbamazepine, we use a lot of phenobarbital and valproic acid mostly. Now we're having levetiracetam in the private pharmacy, so we are getting our patients to be on that as well.
That was awesome. And I'm gonna plug it in the chat, but Dr. Nalucha was actually featured in an amazing podcast when they talk a little bit more about epilepsy in Zambia. It was fascinating. I learned so much about it. And thank you for sharing all of this experience with us. And you mentioned something really interesting that I think we should really highlight, is that there are very few neurologists in Zambia. Can you tell us a little bit more about how many neurologists are there total? How many neurologists are there in your program? What's been changing recently?
Okay, so far we have 8 neurologists. So we had the first cohort of neurologists. Okay, let me put it this way. For some time now, we had one neurologist, Professor Tazanov, who's been in Zambia for a longer time. And then we're joined by Professor Gretchen Biebeck, who has been doing a lot of research in Zambia. And we had no neurology program. So Professor Tazanov was seeing patients, and then we had Dr. Siddiqui joining us from the States. But he was also more research oriented, but he was seeing some patients on the ward as well. So we started the neurology program, I think that was 2019. So it's structured in such a way that you have to do 3 years of internal medicine and then 2 years of full-time neurology residency. So we had our first cohort, which produced about 6 neurologists, 2 pediatric neurologists and 4 adult neurologists. And then at the end of last year, we produced the 7th neurologist, just one, unfortunately. And I am the next one to graduate to be the 8th one. And so we're growing slowly, but the program is being recognized. And now everyone in the country is just trying to get all the neurologists, all the neurology patients to be seen by us. So now we are having a huge workload, but we have seen that in terms of neurology care, we have seen an improvement. We did a stroke study and we noticed that our mortality before we had this neurology program was about 40% inpatient mortality, but now it's reduced to less than 20%.
Wow, Dr. Nolicha, that is amazing. Congratulations on all of your achievements. You're literally an inspiration to all of us, and you're definitely changing like the face of neurology. That is impressive. Your patients and like all of us are super thankful that you've decided to go into this field. And I'll definitely, like, I've been keeping an eye on you for a while now, but everybody, but everybody should, because you're like a rising star. Dr. Matia Rosso, like Matthias, you had a question that I think is very interesting. Do you want to open your mic and share it and like ask Dr. Nolicha?
Yeah, Dr. Nolicha, I was really curious to hear whether, you know, I feel like a lot of the literature, especially our textbooks and our publications, have a focus toward the Western world. I don't know if this is true, but I do feel that a lot of the studies come from, you know, Northern America, come from Europe, lots from China too. I'm curious whether you felt this as a limitation of sorts in keeping up to date with neurology, because I don't know that the base rates of what you see in Zambia reflected in our textbooks, or maybe that's not an issue for you. How have you worked through that, I guess?
Okay, so how can I put it? So there, of course, would have most of these diseases we read about that are mostly in the US, mostly in Europe. And when you come across journals and articles, you don't really have much representation from Africa or even just from the Black population. But we try and see what we can diagnose here. And we've actually seen that some diseases that are said to be only in Europe and in the Western countries and very limited in Africa, we've just realized that what we actually needed was diagnosis by neurologists. I'll give an example of multiple sclerosis. For a long time, we thought it's something that's rare in Africa, but even in Zambia, I think before the neurology program, I think we just had one diagnosis of multiple sclerosis. But now, since we started the neurology program, we've actually noticed we've got quite a number of patients who initially were being labeled as recurrent strokes. And then when we started the program, we investigated these people and we found they've got multiple sclerosis. We found some patients with NMO. So it's actually interesting. And we thought, most of this stuff in literature in terms of epidemiology, the lack of proper diagnostics or neurologists has contributed to us thinking some of these diseases are rare. So now we have morning reports with the neurology residents from Johns Hopkins, and it's interesting to see what they have. And even when we're seeing our patients, we've just told ourselves to think broadly. Of course, we're still limited with the diagnostics, but we try and see if some of these diseases are actually present in our setting. So it's just about keeping an open mind.
I'm so glad you mentioned that, Dr. Nolicha, because I remember learning, as we all do in medical school, that MS is more common further from the equator. And then when I started doing some global work and you look across the globe around the equator, you have to ask yourself, how many neurologists and how many MRIs are there close to the equator, right? And so some of these things that become quote unquote fact, we realize are not accounting for where most of the people in the world live. And so I think, you know, your work and your colleagues' work and Diana and Omar and Gretchen's work, really building that capacity to have neurology doesn't just help the local patients, right, but completely transforms what people understand about neurology, because people might say, oh, there's maybe not much neurologic disease there, but train a few neurologists and the patients will come, right? And you'll see that there's actually a lot of neurologic disease. So I've really enjoyed the chance to work with you and your colleagues through our lecture series that Diana, not really lecture, right? Learning series, because I made you all discuss cases with me each time. And
yeah, it was interesting. It was a great time.
I'm glad, yeah, for me too. And thank you so much for doing this. I think it's so illuminating for everyone to hear about your work and your practice there and your training, and to hear about a case very different, both in the things you would think about early on in the diagnosis, and the complexity, right, of how late it is when patients present with so many. There was HIV, there was cancer, there was a neurologic problem, and the challenges of trying to get treatment, and unfortunately, very different outcome maybe than was hoped for, could have been. So thank you so much for spending time with everyone this morning. Come back anytime if you would like. We do this all the time. And
okay.
I will leave it to, or feel free to bring your residents, or if anyone else would like to present a case. That's a great group. I've worked with them now for a few months virtually, but hopefully someday in person. So I'll hand it back to Maria, who organizes these sessions for the last year. But just want to thank you so much for spending time with us this morning and bringing this case. I'm sure everyone learned a lot. And as Maria said, it's just so inspired to hear that you will be one of the first, I know it sounds like 8th, but still one of the very first neurologists, not just in Zambia, but really in a whole region of Africa, right, where there's really very little or no neurology. So as Maria said, we'll be following your career with great interest.
Sure. Thank you for having me. Thank you for the opportunity. I'll definitely take part again.
Great. All right, take us home, Maria.
Yes, Dr. Nalucha, this was amazing. It was so inspiring to have you here. I knew from the start, where I started trying to put this global virtual morning reports early on, that I wanted you here. So the first person I reached out was Aaron. And thank you so much for coming. I know it's like 5 p.m. for you, so we'll let you enjoy your Saturday evening, but I can't thank you enough from part of like all of the CP Solvers family. We learned a lot about medicine, but also a lot about your incredible impact in the region. Ace, like the first 10 neurologists, that's amazing. You're incredible. Congratulations on finishing this part of your career, and please come back anytime. We'll have you anytime, Monday through Sunday. We'll make it work. So yeah, thank you so much, and hopefully everybody enjoyed it and learned a little bit about it. I learned a lot. I think everybody learned a lot. So thank you so much. Hopefully everyone will enjoy their weekend.
Bye.
Bye, everyone.
Thanks, everyone. Bye.
Bye, guys.